How do you turn on Everyone has a piece of paper. Take out a piece of paper so you can just trace along, write whatever you guys hear is important. If we think something is particularly important to draw along with us, such as the spinal tract, you know, where everything is exactly, we'll let you know. Everyone doing okay? Everyone making it through? How does it feel to almost be done with first year? That's fine. Don't worry about it. You guys will be good. All right, perfect. All right, you guys ready? All right. Let's do it. All right, so what? It's recording. It's recording. All right. So this is what we're going to teach you: spinal tracts and their lesions, strokes, visual field defects, the facial nerve and the brainstem, and then things to study on your own. I can't emphasize this enough. Know what each cranial nerve does, not just for this test, but for every test in the future. They're some of the easiest points you can get. Make sure you know them, okay? Make flashcards, do Anki. Perfect.
And which foramen they come out of?
Which foramen they come out of. They sometimes ask, you know, the patient is presenting with, I don't know, the inability to feel on the face. Which foramen would it come out of? And if it was up here, what would you guys say? What? Superior orbital fissure. If it was over here, what would you say? Foramen rotundum, V2. And if you guys... Perfect, yeah. All right, so the spinal tracts. You guys really have 3 to 4 important ones that you need to memorize, and then a bunch of really random extrapyramidal, I think they're called, ones that you really don't need to learn. You can learn them, they're useful, they'll appear on your test a lot, but you can really figure it out through process of elimination within my own experience. First you have the dorsal columns. Can anyone tell me what they're for? Exactly, proprioception, vibration, fine touch. Spinothalamic tract, what is that for? Perfect. And then cortical spinal tracts. That can be divided into 2, anterior and lateral. Not anterior and posterior, not lateral and medial, anterior and lateral. What is anterior for? What are both for? Movement. Okay, and anterior is for? Yeah, right over here. And lateral is for? Limbs. Lateral limbs. All right. So, this is a very basic picture of what kind of action?
Transverse.
A cross-section specifically? Transverse, that's right. Okay, can anyone tell me where the gray matter is?
Inside. Purple.
Inside, it's the purple, yeah. It's supposed to be gray. And what's on the outside? What is that called?
White matter.
What's the difference between the two?
Cell bodies.
Okay, which one's the cell bodies?
Gray.
Which one's the axons?
White.
What makes the axons white matter?
Myelin.
Myelin. So, between these two, where are the tracks?
White matter.
Well, yes, that's right, white matter. Perfect. This is a very complicated thing, right? It's complicated, you guys don't want to learn it? That's what you want to learn. This is the really simple one. Okay. Can anyone tell me what's the difference between, so where's the gray matter?
Inside.
Inside. So over here is the gray matter. It could be divided into two. Okay? Which way can you divide it? Anterior and posterior, or?
Dorsal and ventral.
Yes, they're the same thing. Don't get confused with that. Okay? Which one's anterior, which one's posterior?
Dorsal, ventral.
Yeah, so this is your ventral, aka your anterior side. That over there is your posterior, aka dorsal side. Okay? So these are your ventral / anterior horns. Draw this out if you don't already know this or if you want to solidify it. These are your ventral / anterior horns, and these are your dorsal horns. What are your anterior horns for? What kind of cell bodies do they contain? Motor, okay? And therefore, the dorsal holds the? Perfect. Okay, so over here we have 3 tracks outlined, okay? This is your dorsal column. That's for your? Sensory, okay? Your corticospinal is for your? Motor, and your spinothalamic is? Pain and temperature. There's one missing here, okay? Which one do you, what?
The anterior corticospinal.
Yes, the anterior corticospinal. Okay, where do you guys think it is? Yeah, anterior, right over here-ish. Okay? Those are the ones you need to worry about. So, what do you guys think the difference is between ascending and descending tracks?
Yeah.
Yeah, okay, perfect. So, which one's sensory? Descending. No, ascending. Ascending. Okay? And which are the 2 ascending tracks? Yes, okay? And then therefore your 2 descending tracks come from your brain. Therefore they're called cortico, and then go down the spine. Spinal, that's why they're the motor tracks, okay? Alright, so to break it down for you, you have your dorsal, spinothalamic, lateral, and anterior corticospinal, okay? What they do, you guys seem to know it really, really well. And then where you decussate. Can anyone tell me what decussation means? Crossing over. Why are you guys saying that you don't have good neuro teachers? You guys clearly know this stuff. Great, honestly, great job. So, because this is really what you need to know. Okay, most of them decussate where? The medulla. The one exception is the spinothalamic tract. Where does that decussate? Yeah, the anterior white commissure. Can anyone tell me where that is? Yeah, anteriorly. That's, yeah, anteriorly. Okay, which lesion is the anterior white commissure first hit? What disease? What? Did you guys learn syringomyelia? No? Okay, forget it. Sorry. Don't need to know it then.
They probably still test us.
What? Alright. Guys, calm down. Tip it to David?
Yeah, just raise it up.
Just the tip? There we go. Bottle is not in the way. Okay, cool. Okay. You guys. Alright, so how many nerves? 3. Okay, 3. Remember, what are the 2 nerves for the corticospinal tracts? Yeah, the upper and the motor, the upper motor neuron and the lower motor neuron. Do you guys want us to draw out the tracks for you? Okay.
Okay, really fast. What's this? Okay, and then which one is this and which one is this? So is this After. And then what senses come through here? Sorry, I gotta get away. What comes through here? Sensory. What comes out through here? Okay. So where does the anterior white commissure? Where is that? So right here, this is the anterior white commissure. So the spinothalamic tract, as it comes through the sensory tract, it comes and it actually crosses. It crosses at the anterior white commissure. Sorry, it comes in like this, crosses at the anterior white commissure, and then comes up and goes up contralaterally. So where we said it decussates at the side of the spinal cord. So this part right here is the anterior commissure. So what he was talking about, I don't think you need to know it, but so syringomyelia, basically, you'll learn it next year. There's a lesion over here. There's some sort of canal that causes a lesion at the anterior commissure, and that just pretty much causes the lesion there, so you get loss of sensation. Pain and temperature.
Is it contralateral or what?
So you get it, it's ipsilateral.
No, it's both. It happens in the center, so it affects both
So it
sides.
affects both at the site of the lesion. So whatever spinal cord tract there is, that's the lesion that you get at that specific part. So you lose your pain and temperature at that specific spinal cord.
If you guys didn't learn it, you don't need to know it
You'll learn
until
it
next
next
year. Yeah. All right. So for sensory, there are 3 nerves. What does it mean by 3 nerves? Yeah, 3 nerves that it ascends through. Okay. So the first one, where do you think it starts? David, can you redraw that, please? Where do you guys think the first one starts? Let's say I prick my thumb. Where will it? Yeah, it'll start right here. Okay? That long one nerve will travel all the way up here, up to my dorsal root ganglion. Okay? What's located in the dorsal root ganglion? Okay. The soma, the cell body to this nerve. Can you draw it over? So this is the dorsal root ganglion. This is going to be where the cell body is. This is where the information comes from, and then it's going to go where? No, it's going to ascend. Right? To the spinal. Right? Does it ascend first?
It comes in through the dorsal.
Does it go in through the dorsal? Sorry, guys. Just to make sure.
What? No, it says up there.
They're right? Okay. It goes into the dorsal column. That's where it goes through. All right. So the first one comes.
Foul.
It's 5 minutes.
Okay, so the first one comes from wherever you felt the sensation. If we're going with general sensation, the first one comes from wherever you felt the sensation. We'll then go to the dorsal columns, and that's the first place that it synapses, right? The dorsal columns. Then it will. Then the second. So that's gray matter. That's the first place it decussates. Not decussates. That's the first place it synapses. What? That's
It doesn't say that.
okay. Then
No, he sends off one branch.
So it continues going up.
okay. Then honestly, I'm sorry. Then I don't want to confuse
You guys are right. So it comes in.
I'm sorry.
It
David
comes
knows
in
better.
from the dorsal root ganglion, right? Nothing synapses. It continues, and it goes straight posteriorly, and then you have 2. What are the names of the 2 different tracks? Okay, which one's on the outside? Which one's more medial? I'll take your word for it. Okay, yeah. So basically, it continues up. Okay, so it continues up the dorsal root, and then it continues up. And you guys said, where's the first place that it decussates?
Not decussate, synapses.
Synapses, okay. So it's synapses, and once it's synapses, it actually decussates as well, right?
It decussates in the medulla.
So okay, so let's say you have,
In the nucleus.
right.
Bacillus nucleus.
So here, let's say it goes to the nucleus. There's a nucleus cuneatus and nucleus fasciculus, gracilis, and it synapses, and then it goes up contralaterally, and then where's the next place it synapses once it goes up? Thalamus. VPL specifically, okay? And then once it synapses there, that's the second synapse, and then it goes, and where's its final destination? Somatosensory. Is that precentral or postcentral? Postcentral is sensory, precentral is motor, right? Okay. So we have 3 different neurons, 2 synapses, one in the medulla and one in the thalamus, the VPL. What's the VPN?
What is VPL?
Oh, it's for the face.
Okay.
Sensation of the face.
So VPM is the same thing, except it's for all the sensations in the face, okay?
What does DPM stand for?
Ventral posterior medial, and then there's ventral posterior lateral, okay?
And then for the you guys, and then for the corticospinal tract, it goes up. It goes here from the brain, from the cortex, and then descends. Okay, and then there's only going to be one synapse because it's only 2 neurons. Where's the synapse going to be?
So the spinal cord.
What? Yeah, where within the spinal cord? Within the ventral horns. Yeah, within the gray matter. Okay, so you have 1 and 2. The first one comes from the brain. Where will it decussate? In the medullary pyramids. It goes to the other side and then travels down. Okay? It will synapse at whatever level it's supposed to get out at. So let's say you're going to move your middle finger. It's going to decussate at C7. I'm not going to decussate. It's going to synapse at C7, and then it's going to leave. The lower motor neuron is then going to leave at that level. Okay? Yeah.
Do we need to know like the interneurons at that level and stuff?
What do you mean? What does that have to do with it?
That makes sense.
Do you need to know the dermatomes?
No, it's okay.
Okay. Which of these lesions have you guys heard in class? Okay. What? I remember learning Brown, Card, ALS, polio.
I think it's helpful to teach them Brown and Card because then they'll understand.
He didn't say the last one, but he's going to probably do the last one.
Yeah.
Okay, you guys. Okay, so Brown-Séquard is going to be. Brown-Séquard is a really amazing disorder. It's when someone. No, it amazes me. It's when someone stabs you. One side of the spinal cord, just one half of it, either the left or the right. What would you expect as a layman, as someone who hasn't studied medicine, to feel? Where would you lose sensation and ability to move? You'd expect complete ipsilateral of everything, not being able. So let's say I was stabbed right here. You'd expect me to not be able to feel anything on my left leg or move anything on my left leg, right? And for the most part, that's true. But where's the one part? What's the one tract that doesn't decussate in the medulla? What's the one tract that decussates? Spinothalamic. And therefore, because it decussates immediately upon entering, so let's say all the pain and temperature from my right leg comes in at this level, enters my spinal cord, decussates into the left side of my spinal cord, and then starts traveling up. Since I'm stabbed right here, right, it's going to affect the pain and temperature sensation of my right leg. Okay? despite being stabbed on the left side, I'm going to lose pain and temperature sensation on which leg? My right leg. Do you guys understand that?
Do you feel pain on the dermatome though? Or where you
What?
get stabbed though?
You will feel pain on that one dermatome for pain and temperature
And
sensation.
the other one below that.
And anything below that, you're still going to have pain and temperature for your left leg, but you're no longer going to have it on your right. And that's because all the pain and temperature from your left leg has already decussated at the level that it came in on the spinal cord. Okay? What?
Can you explain the ipsilateral?
Like I use
The other track lesions?
All of these other, or you're saying for this? What?
Something we need to know also.
KD's,
That's with
yeah.
dorsal.
Wait, do you guys want me to go in more on this, or do you guys?
Are you guys clear on Brown-Séquard? Like, do you guys understand? If you understand that, you'll understand most of the tracks, because that pretty much covers all the different tracks, like, and what their functions are, if you understand Brown-Séquard. And if you know, like, a lesion in a specific area, then you'll know what each function is, because you'll know what's affected and what's affected below and what's affected above. Did you talk about the, like, lower motor neuron lesions and stuff? Okay, so one more thing, when you have, let's say you have a lesion, let's say you have a hemisection of the spinal cord on this side, okay? So we touched on what happens to your, so you guys know the difference between an upper motor neuron lesion and a lower motor neuron?
Yeah.
No? Yeah? Okay, so an upper motor neuron lesion, you have a lesion in the cortical spinal tract, right? So when you have a lesion of the spinal cord, all the tracts that are coming down in the white matter, they're severed, right? Also, at that specific location, you'll have a lower motor neuron lesion. So what's the difference? Like, what do you see? I'm not sure you guys need to know this, but it helps to understand it. So if you have an upper motor neuron lesion, that's basically saying that all the upper motor neurons that are leading to the, because where did the upper motor neurons eventually synapse on? Lower neurons, right? So when you have a lesion here, that's saying that at this specific area of the spinal cord and above, you're going to have all upper motor neuron signs. And at the specific level that the spinal cord is severed, you're going to have lower motor neuron signs. Lower motor neuron signs are more like you have flaccid paralysis. Basically, you don't have reflexes, all those types of things. Upper motor neurons, which I think is probably too much, like I don't think they know.
No, they do need to know.
So, okay, so upper motor neurons, when you have that, that means that the lower motor neurons are now not under the influence of the upper motor neurons, so everything's going to be increased. You're going to get increased reflexes, you're going to get increased tone, you're going to get, what else? You're going to get spastic paralysis. So, and the difference between that is, that's for upper motor neurons. For lower motor neurons, basically the neurons that are going straight to the muscles are severed. So the types of things you'll see with that are like loss of tone, loss of muscle tone. You'll see flaccid paralysis. So the difference between spastic paralysis and flaccid, spastic means that you're still paralyzed, but your muscles are really tense. Whereas flaccid paralysis, you're just completely like loose. Like that's the difference between if you have a lesion in the lower motor neuron or the upper motor neuron. Okay, and then you'll have something called, well, there's something called fasciculations, and fasciculations you'll see with a lower motor neuron lesion, and what that means basically is since you lost the control of the upper motor neuron lesions, then it's going to try to fire more to try to get the lower motor, like try to get your muscles working. So it's going to be highly sensitive. So you're going to get these slight like jolts in your limbs, and those are fasciculations. And you'll see those with lower motor neuron lesions. Okay? So that's just a basic run through of upper and lower motor neuron. And like Michael said, you'll have the lesions in the dorsal columns, you'll have the lesions in the spinal column tract, and everything else is pretty much.
So for this motor neuron, for the motor tracts, the corticospinal tracts, okay? If you have an upper motor neuron lesion, everything goes up, okay? You have increased or decreased reflexes?
Increased.
Increased. Increased or decreased tone?
Increased.
everything is increased except for one thing. What's that one thing that David just mentioned? Fasciculations. Fasciculations is only seen with lower motor neuron lesions, okay? In lower motor neuron lesions, everything goes down, okay? So will you have increased or decreased reflexes? Will you have increased or decreased tone?
Decrease.
How will the patient present? With atrophy or no atrophy? Atrophy, there you go. A lower motor neuron lesion is going to be seen over here in the columns, okay? Because that's where the cell bodies of what are? The motor neuron of the lower motor neurons are. This is where the cell bodies of the second neuron, the lower motor neurons, are. If you have a problem with the white matter, a problem with the tract, which tract are we talking about? The corticospinal tract from the brain to the body, corticospinal. It's going to be in the actual tract. So upper motor neuron lesions are found where? What's damaged? White or gray matter? White matter of the spinal cord is damaged. The white matter of the spinal cord is damaged. Gray matter problem of the spinal cord will manifest as a lower motor neuron lesion. Where does everything go up? Lesion. Where does everything go down? Except for fasciculations is seen in
Lower motor neuron.
Okay.
Why do you get atrophy with a lower motor neuron lesion? Exactly. I like to understand why, so if you know why, then it makes it easier.
You see why?
What?
Why do you think?
Because basically you have trophic factors. Once nerves innervating a muscle, you have both trophic factors, and since it's innervating it, it allows it to.
What trophic factors?
Okay, so growth factors. So when a nerve is basically synapsing on a muscle, not only does it help it continue to contract and it helps it stay strong, but it also releases growth factors to keep it alive and well. So when you have a lower motor neuron lesion, it causes the muscle to atrophy, and that's why.
Yes.
Could you explain one more time why white and gray are upper and
Oh
lower?
yeah, sure. Okay, so where does your upper motor neuron come from? The cortex. Its location is the cell body is located in the cortex, and then it travels down. It decussates where? The medullary pyramids, and then it travels down. Okay, where is it? What level will it travel down until? The level it's the nerve is eventually going to come out, and then its synapse is where? Its synapse is right here.
I
Okay.
think maybe that's why it's not.
Okay. Its synapse is right here in the column, in the ventral columns, in the anterior columns. Okay. And then since its synapse is here, what starts here?
Third nerve.
What? The second nerve. We're talking about motor, so there's only 1, 2. Okay, for sensory there's 3. So since this is motor, you have the upper motor neuron traveled all the way down, decussated, and then got here. Okay, and then here's where the cell body of the second one, the lower motor neuron is, and then it's going to come out and tell your hand to move, tell your leg to move. Okay, so if you have the only thing that's in the white matter is what? The only motor thing in the white matter is the upper motor neuron, right? You do have the end of the axon within the upper motor neuron, right? However, despite that, it's still the soma. It's still a much bigger deal. It's still the cell. You guys know soma means cell body? Okay, it's still the soma cell body that's here in the over here in the for the lower motor neuron here in the gray matter, here in the ventral horn of the gray matter. So that's why a lesion over here will be a lower motor neuron lesion, and then a lesion here will be an upper motor neuron lesion. Are you sure that
Yeah,
that's good?
yeah.
Can you explain specifically why you have increased reflexes when you come up the upper motor neuron?
David's watching Jeep on this, so he's better at me.
I like understanding why. So basically, think of the upper motor neurons as controlling the lower motor neuron. It's sort of like an inhibitory neuron on the lower motor neuron. When you lose the inhibition, the lower motor neurons basically they just go crazy and they have no inhibition. So everything becomes greater. So your reflexes will become greater because there's nothing inhibiting
So
it.
it's not a stimulatory tract.
The upper motor and the lower
Yeah,
motor.
it's always
So it
inhibitory.
is a
Oh, okay.
it's a stimulatory in the sense that the signal travels from the upper motor neuron to lower neuron, but it still has some sort of like it keeps everything sort of
It still has
you
a
know,
basal tone
in
that needs to
equilibrium.
be
So when you
inhibited.
lose it, and then you'll learn next year there's something called Babinski sign.
Yeah.
No, they need to know it this year
So you
too.
know what Babinski sign is, and so basically that's a form of inhibition of an upper motor neuron on the left.
Okay, so where do you see the Babinski sign? In which lesion? And you see it naturally in babies, and then they lose it within the first year. And then which lesion will you see it in? Upper or motor neuron lesion?
Upper.
You see it in upper. Can anyone show me what Babinski's looks like?
When
It's
you
like
stroke
this.
the bottom of the foot and you go
Now you gotta take off your shoes and show.
Yeah. Anyone want to demonstrate on it?
There you go.
You stroke it and then it goes up, right? I can't do it here, but you stroke it and it goes up.
Isabel's like, what are you doing?
This isn't their marker, it's the marker here, so don't worry. Gobi, you got it? Yeah. Okay. Alright. Okay. I really want to go over a few of these because they are important and they may come up. Polio is just a lower motor neuron lesion. Therefore, where is the lesion? Where in the spinal cord? White or gray matter? Gray matter. Specifically, which part of the gray matter? Ventral horn. Perfect. ALS is both combined lower and upper motor neuron lesion. Okay? So if you see both upper and motor neuron lesion problems, what's the answer?
ALS.
ALS. Okay? Who has ALS?
Lou Gehrig.
Lou Gehrig, Stephen Hoffman. It's only Stephen. What did I say? Hoffman. Stephen Hawking. It's only a motor neuron problem. They're going to have perfect sensation. They can still feel everything. It's just a motor. So if you see mixed both fasciculations and increased reflexes, that's a big clue that it's ALS. Okay, you're going to see it in men around the age 40 to 50 is when it begins. 30 to 50, right?
Yeah.
Around there. Complete occlusion of the anterior spinal artery. Where is the anterior spinal artery? Yeah, anteriorly. Between where?
Between the pubic artery.
Yeah, exactly. It's going to be located right here. Everything from levels, no, even over here. Everything except the dorsal columns is going to be damaged. Okay? So what's the only thing the patient is going to have?
The motor.
No, fine touch, vibration, proprioception, but both their motor and their pain and temperature sensation is going to be gone with an SA infarct. Caves dorsalis, that's the third stage of
Syphilis.
syphilis, okay? It comes with Argyll Robertson, the prostitute's pupil, where you, what is it? You can't,
but don't react.
that's the one.
What?
Yeah, accommodate, but don't react.
Syringomyelia affects what region first?
Anterior commissure.
The anterior white commissure, which is where what decussates? Spinothalamic tract, which is for? Where does everything else decussate? Medulla. Knowing those basics, you guys are really good. Vitamin B12 deficiency, this is going to be like mixed motor and sensory problems. I don't think you're going to need to know it. You really need to know it for next year when you want to distinguish between B9 and B12 deficiencies from biochem, so worry about that then. And we went over Brown-Séquard syndrome. What's the only thing that's going to be contralateral loss? Pain and temperature. If I get stabbed on my left side, I'm going to lose pain and temperature for the right side below the lesion. Okay? And why is that? Exactly. It decussates where it comes in, not the medullary pyramids. So since it decussates over down here, it goes across and then comes up. That's the lesion, that's the part that's going to be hurt. But on my left side, I'm still going, if you light a fire under my left toe, I'm still going to feel it because it's already decussated it to my right side.
But for the other tracks, if you cut it above the lesion,
Yeah.
wouldn't it be
Won't it be?
contralateral?
What do you mean?
Like the effect.
The
That's what I'm trying to like because it doesn't get to the medulla.
yeah.
For the other tracks, you cut above it. Above the lesion. Yeah, the decusation.
Yeah, well, since the decusation occurs in the medulla for the other tracks, it's not, you're never going to get stabbed over here, and your primary problem is, you know, I have pain and temperature loss on one side. Your main problem is going to be I can't move my diaphragm. Because what controls the diaphragm, guys?
C3, 4, and 5.
C3, 4, and 5. Good.
Did you say for the anterior spinal artery, if there's a conclusion that would be a problem with high section?
There won't be a problem. There won't. The dorsal columns are good. You're going to lose pain and temperature sensation, motor problems, but your fine touch, your proprioception, all that is going to.
Pavus versalis is the opposite. Pavus versalis is just the dorsal column.
Exactly. Perfect. All right. So you guys have we have a lot more to go on. So yeah, one more question.
Yeah. So if you were to ask us some sort of like blood flow problem, trying to get at the cuneate or gracilis nuclei, what artery would we be including?
To the what?
So to try to do the reverse instead of trying to slice the spinal cord, trying to get us to think upper motor injury with like loss of sensation and collateral contact. If you wanted to say the cuneate, whatever, gracilla or cuneate nucleus is somehow damaged, what artery are we looking at?
That's the posterior spinal artery. So the anterior spinal artery is the anterior portion of the spinal cord, and there's a PC.
There's two.
There's two posterior spinal arteries. They rarely ask about those.
Yeah, I have never once seen a question on it. So, but yeah, it will be the posterior spinal artery. Yeah. One for each side. All right. So. All right. Dave?
Okay, so this part is pretty quick. So you guys know the blood supply to the brain, right? Yeah. Okay. So what are the two main arteries that supply the brain? Start lower and go higher. So. Okay, and where does the vertebral artery come from? Subclavian, right? Okay, so it comes from the subclavian, and then where does it travel along? How does it get to the brain? Right, so what are those called? Vertebral canal, okay? So it leads through the vertebral canals, and then what's the part, how does it get into the actual skull? What does it travel through? Right? So through the foramen magnum, the vertebral arteries come up, and then so over here, okay. So over here you'll see the two vertebral arteries, and then what do they turn into? Right? And where does the basilar artery travel along? Right? So it travels along the pons, and then so let's go down and then we'll move up. So we'll start with the vertebral and then we'll go to the internal carotid. So from here, let's see if there's a better picture.
Yeah, go to the next one. Previous.
Okay. So from here, we see that we have the two vertebral arteries turning into the basilar artery. And what are these arteries coming off right where the basilar artery is? Okay. And then what are these arteries over here? Okay. And so do you guys know what part of the brainstem these actually supply? The name kind of gives it away, but so posterior inferior cerebellar artery, where does that supply? Okay. And then, so the basilar we said goes along the pons, and then we said we have the anterior inferior cerebellar artery, and then, so these are labeled, you guys can read it, but, so you have the posterior cerebral artery, that right at the end of the basilar artery, you got the posterior cerebral artery, and then I don't really like.
You guys, where is this all located? Where is the circle of Willis located?
Around the optic chiasm.
Yeah, I mean, specific.
Like which part of the brain, like which layer of the brain? So remember, there's the different like arachnoid.
Right, yeah. Where? Who said it? Subarachnoid.
Subarachnoid space. So what's surrounding the circle of Willis? CSF, right? So when you guys learn about, have you guys learned about subarachnoid hemorrhage? The worst headache of my life. You guys heard that? So when you get an aneurysm or you get a rupture of one of the arteries in the circle of Willis, then you get bleeding into the CSF. And so that's basically what causes what they call the worst headache. Patients aren't going to come into the ER saying I have the worst headache of my life. They don't know what the worst headache is.
They will on questions though.
On questions, they'll say it's the worst headache of my life, and immediately you guys just go to subarachnoid hemorrhage, and it's going to be one of the arteries in the circle of Willis. Okay, so basilar artery, we said we get the posterior. So we have the superior cerebellar arteries, and then what's the next artery right on top of that? Posterior cerebral, right? Okay. From the posterior cerebral, that's the part where the vertebral artery blood supply ends, okay? So we have a dual blood supply. We have from the vertebral arteries, and then what's the other main arteries that supply the brain? Internal carotid. So the posterior communicating artery right here, that's what connects the anterior supply to the posterior supply, okay? So from the posterior communicating artery, that leads into the internal carotid. And so, quick overview, where does the internal carotid come up and enter into the skull?
Carotid canal.
Carotid canal, right? And so, going back down a little, the carotid canal, where does it originate from? So, let's start from down actually. So, you get your common carotid, which turns into the, and then the internal carotid supplies the inside or the outside of the skull? Inside. And then the external carotid? Outside. So the internal carotid, we said, enters through the carotid canal. And then that's where you can see right here, the carotid canal, basically the internal carotid exits, and this is basically the continuation of the internal carotid. And it actually turns, it has 3 different branch points. So the main artery that continues along, the main artery that continues along through between the frontal lobe and the temporal lobe, that's the middle cerebral. And then from the internal carotid, you also have a branch coming straight out, going anteriorly, and what's that called? Okay, so actually, what's the connecting one right there between the two? And then you'll continue as what 2 arteries? Cerebral. Okay, so that's basically an overview, and now I think the most important part of this is understanding when you have a lesion in these arteries, what happens, and basically which part of the brain do each of these supply. So here, okay, if we look at the lateral portion of the brain here, what artery supplies this lateral portion of the brain? Middle cerebral, okay. And then, so we said, remember, we said the middle cerebral comes out, and it goes between the temporal. So remember, you have your frontal lobe and you have your temporal lobes. The middle cerebral pretty much goes, and its route is between the frontal lobe and the temporal, and it kind of courses along to the side of the brain. And eventually, it supplies both sides of the external lateral portion of the brain. And the anterior cerebral, you can see it's going actually medially, longitudinally through the center of the brain, and then it courses, and here's you'll see a cross section of the brain. And so all this blue is supplied by the anterior cerebral. Okay. So all this section right here is supplied by the anterior cerebral, and we said that the lateral portion here is the middle cerebral, and then what portion is supplied by the pink? Posterior cerebral. Okay. So you guys have learned about the precentral, postcentral. So the types of questions they're going to ask for these are basically, if you have, let's say you have an occlusion of the middle cerebral artery, you have an occlusion of the anterior cerebral artery, they're going to ask you what sort of symptoms are you going to expect. So you guys have learned of like the homunculus. The homunculus, you guys know what that? Okay. So which portion of the homunculus is supplied by the anterior cerebral artery. Okay, is that for motor or sensory? Both, right? And so more anteriorly, you'll see the motor, and then post. But if they say it's an ACA infarct, you're going to have both motor and sensory lesions for the lower limbs. And then same thing for the external, sorry, it's the same thing for the middle cerebral. You're going to basically have the same sensory and motor deficits, but if you look at the homunculus, it basically shows that it's supplying the face and the upper limbs. So any deficit you see that involves upper limbs or facial defects, it's always going to point towards anterior cerebral artery. Okay?
And what other, no, you mean middle cerebral.
Middle cerebral artery, sorry.
And what other two problems will you often see with middle cerebral artery occlusion? Yeah, Broca's and what's the difference between the two? Start with Broca's. What's Broca's?
Speech production.
And what's Wernicke's?
Okay, so so fun fact, right here, this part of the motor area is actually where the face is. So the fact that the Broca's area, which is basically, it forms all the plans for speech, like it's basically the reason it's right there, it formulates all the plans for speaking, and since the motor for the face is right there, that's what actually causes the speaking. So there's something called dysarthria. You guys, I don't think you'll have to know it, but it helps to know. Dysarthria is basically, you don't have a problem with Broca's area. You can formulate speech fine, but it's actually the motor area of moving your lips that don't work. So although your brain, your Broca's area is working fine, you know how to make the speech, it's just not going to come out. So next year you guys will get questions where they'll ask you, do you know the difference? This person basically has trouble articulating, he can't speak right, but they'll give you some information where you can tell the difference between, is it a problem with Broca's area or is it a motor problem? And so that's useful to know.
What do you guys think you'll still be able to do that he won't be able to do with Broca's?
Right speech?
You'll still be able to write, exactly. And that's one good way to distinguish between the two. If it's just the face that's affected, his hands aren't affected, he can still write speech. Okay? If he has the motor problem, but not a Broca's problem.
Okay, yeah. And so Wernicke's, basically comprehension. So, and it's useful to know that when you have a lesion of Wernicke's, although they can't comprehend, they can speak still, but they're very incoherent. They'll speak, they'll talk, but it won't really make much sense. Although they are able to talk, because they can't comprehend, it's difficult to formulate actual real sentences. But they will still be able to talk. And I don't think you guys need to know about the arcuate fasciculus, so.
Arcuate fasciculus connects the two, Wernicke's and Broca's.
You know that?
Yeah.
So if you have a lesion there, one person, do you know what you'll see?
Is it an auditory problem?
But it won't be an auditory problem. Does that, who?
That's what he said.
What?
Yeah, yeah,
No.
you got it.
You
You
can
said
repeat the words.
you can't repeat
You
the
don't have
word.
a problem
You're too
repeating.
light.
Perfect.
If
You
you have
can
an injury
repeat
with
something that
Broca,
somebody tells
you
you.
can't write a response.
You can't write. With Broca's,
Wait,
you
you
can't
can't.
speak, you can't write. You can't
I thought
form.
Broca's was just like the speaking part.
No, Broca's is both speaking and writing. The patient won't be able to write anymore if they have a Broca's lesion.
Hey, Michael. You're up.
What's the arcuate?
So the arcuate,
Go ahead. What? You guys. Okay, so what connects Broca's area to Wernicke's? The arcuate, okay? So if you have a lesion just there, only there, the patient will seem fine. But then if you talk to them, they won't be able to repeat after you. Let's say you ask them, repeat, Mary has sheep. They won't be able to do that, okay? It's that simple. I don't know.
it's the brain at home.
It's
Still
not,
don't know the brain. The brain is very calm.
I don't know. It's because it has to do with comprehension and then forming language. So because you don't have a connection between the two, because someone is speaking to you, you can't then take that processing, putting it into your repeat after them. You can't connect it. I don't know. That's the best I
That was
can
good.
do. Okay. All right. Everyone good so far?
Yeah.
Okay.
Give us chances then.
Okay. So, you guys have studied the optic tract, the optic lesions.
We have to know that.
You guys do need to know this, though. Okay.
They basically for cranial nerves didn't cover it in depth because we already covered it, but I know like we're gonna need to know.
Okay.
Just to let you know.
Okay.
They
This
said it, they didn't explain it.
What is the only cranial nerve that has to do with this? Two. One is for what? Olfaction. It's not even a real cranial nerve. It's just like the first guy who said it, thought of it, and they made it a cranial nerve. Same with two, actually. But cranial. Yeah, to the genius who looked at a shark and figured it out. But cranial nerve 2 is the only one that you have to worry about. But what about 3, 4, 5, 6, even 7? Oh, why not them? They're motor. This is actual visual field problems, okay? So, what is this structure over here? Your eye. What is this structure? The optic nerve. Exactly. What's this structure? What's this? What's this? What? Lateral geniculate nucleus. Okay, then it becomes two things. You guys want to guess? It's two lobes. Which two lobes? Temporal and parietal. Okay? It goes through the temporal and parietal to get to the occipital, which is right over here. Okay? And you can have lesions in any of these regions, and they'll present differently. But when you think about it, it will make sense. Okay? First, let's start with the visual fields. Okay? This is what you're looking at. Okay? Things from all the way over here on your temporal side are going to be processed by the nasal area. Let's say I'm looking to the right. I want to see something on my right. I want to see David. It's going to be processed on the nasal area of my right eye and on the temporal area of my left eye. Okay, this is a hard concept to learn, but a very important concept to learn. Things that are on the bottom are going to be processed by which part of my eye? On the top part of my eye. That is why your eye sees things inverted to how they actually are. Okay? I know you guys see me as if I'm standing right side up by everything. That's because your occipital lobe processes everything and switches it the right way. But the way you actually see things is reversed because of how light enters your eye. So things on the bottom enter the top, things on the right enter on your left. Okay? This is an important concept to know because I had a question on it on the parts. Okay? So if I have a problem with my eye, then I'm just not going to be able to see with that eye. The same is true of the next part, the optic nerve. Okay, if I have a lesion on my optic nerve, I'm not going to also be able to see with that one eye. Okay? When it gets tricky is as you go forward. Okay? Because here is where decussation occurs. Here's where crossing over occurs. Okay? Everything from this region, all the blue, okay, everything from the nasal side decussates, while everything from the temporal side stays on the same side, okay? So that means all my vision from my nasal fields, everything that I see on the nasal fields on the opposite sides, goes here. Maybe I'm getting a little too complicated, right? Okay.
You're crushing it. It's great.
All right. Then, so it decussates over here, while one side stays on the same side. So everything so what will happen by the time I get to the optic tract is that everything that I see on the left side will actually be in my right optic tract, while everything I see on the right side will be in my left optic tract, okay? By all these crossing overs that occur where? By the optic chiasm, okay? It finds its way, the optic tract ends, where does it synapse? Lateral geniculate body nucleus, okay? Then it will travel into the temporal lobe and the parietal lobe, okay? In the temporal and the parietal lobe, because they're divided, you're going to, the stuff from the upper part of the eye goes through which lobe do you guys think? What's upper and what's lower? What's upper, your temporal or your parietal lobe? Your parietal lobe. So which one do you think goes through it?
Lower visual field.
Yeah, exactly. Your lower visual field. Why is that? Because it goes reversed. Okay? And what goes through your temporal lobe? Upper visual field. Because it's on the lower side, but everything reverses. Okay? Your temporal visual field, what goes through it is also known as the Mayer's loop. I feel like Dr. Evil, Mayer's loop. The way I remember it is Mayer, anyone knows a guy named Mayer? He has like gray stuff here on his where his temporal area is. That's how I remember temporal. And dorsal optic radiation, I think of a dorsal fin. And what's on the top, what's dorsal of your brain, your parietal lobe. So that's how I remember the difference between dorsal optic radiation over here, which goes through the parietal lobe, and the Mayer's loop, which goes through the temporal lobe. Okay? And then it makes its way to your occipital lobe. Okay? Your occipital lobe, you're going to have blindness on one side, just like you see with the optic tract, okay? You're going to see it on just this side of both eyes, not one eye, but this side of both eyes.
Wouldn't that be the optic nerve?
What? No, optic tract. Okay? The difference is that you're going to be that you're going to have macular sparing. Okay? Macular sparing means that the center of your eye on both eyes is going to be fine, and the reason for that is that why do you think you might get a problem with your occipital lobe? What might
In the back of the head.
PCA infarct, okay? A PCA infarct can cause it, okay? So if you have a stroke on your PCA, you're going to occlude your occipital lobe. You're going to have a problem there, and you're going to have a problem with seeing from everything that's being supplied there. However, your PCA supplies from both sides, supplies the macular region from both eyes. So if you have an infarct of your left PCA, the left macular region is still going to be supplied by your right PCA. Okay? Okay. The reason you'd have a problem with your occipital lobe is if you had an infarct of what was supplying it. What supplies it?
PCA.
Your PCA. So your PCA supplies mainly just that side of the occipital lobe, that one side. However, it also supplies a little bit of the other occipital lobe, the other side of the brain. Okay? So it supplies its own side of the brain and just a little part of the other brain. Okay? Of the other side of the brain.
The region of overlap or the
And the region of overlap is exactly where the macula is.
So it works as an advantage, the compensation allows
Yeah.
you to see more in that stuff.
Exactly. So that's how you're going to tell the difference between an optic tract problem and occipital lobe problem. So let's go through each of the problems and just make sure. So over here, if you have an eye problem and a problem with the optic nerve, it's going to be the same thing. You can't see with one eye, okay? If you have a problem at the optic chiasm, can anyone give me an example of a problem with the optic?
pituitary tumor.
Exactly, a pituitary tumor because it sits on the
Cell turcica.
sella turcica. Exactly. since it does that, you're going to it's going to compress the brain, and it's going to compress exactly where everything decussates. And what are the two things that decussate? Things on the nasal side. But the nasal side gets peripheral vision. Exactly. It's going to, so since your peripheral vision goes through your nasal, goes to the nasal part of the eye, and then that part of the optic nerve decussates on the optic chiasm, you're not going to be able to see peripherally. And so those patients are going to present as if they just got in a car crash. I had no clue why I got into that car crash. I didn't see him. And then you're going to test him, and you're going to do this, and he's not going to be able to see that. Yes.
But with the optic chiasm injury, you can also injure like the outside of the optic chiasm.
You don't. You don't. Because it sits right here. It compresses right here way before it's going to compress this. And typically pituitary tumors, like prolactinomas, don't grow to immense sizes. They grow to a size that will only compress the structure. It won't completely obliterate it.
You'd be blind if that's your whole optic.
Yeah, you would be blind if it got everything. It is going to be gradual, but it will gradually do this and then probably end up here.
Only side note is, if you have an internal carotid artery aneurysm, those go along the sides of the optic chiasm. This year, don't worry about it. Next year, you might see something where you just have one side, and so you can actually get a one-sided lesion on
this year. All right. If you have so that's the optic chiasm. Next, you have the optic tract. Do not confuse the optic nerve, which is the actual nerve, cranial nerve number 2, with the optic tract. The optic nerve, a problem there is going to be one-eye blindness. The optic tract is going to be blindness of this side, of the left side of both eyes, or the right side of both eyes, depending on which optic tract. Okay? Then it finds its way to the lateral geniculate body. Synapse is there. Okay? And then what happens? And then it travels through which two lobes? Parietal and temporal. Okay? The temporal lobe, if you have a lesion there, what's the name of the loop that goes through? Meyer loop, because Meyer has gray hair right here on his temples. Okay? Then you're going to not be able to see which side. Up or upper, or you're not going to be able to see upper, because everything is reversed. Exactly. But if you have a problem with the dorsal optic it should show I don't know why it doesn't have a dorsal lower one. But if you have a problem with the dorsal optic radiation, what are you going to see? Lower field problem. And where's the dorsal optic radiation? It's as if you had the lower half. Okay? So I don't know why this one doesn't show it, but imagine it just showed a lower half, a lower quadrant.
Where would the lesion be on the picture?
Oh, okay. The lesion will be right here in the blue. Just this blue. Just as this is just the red, and this passes through which lobe? Temporal lobe, and therefore causes a right-sided, an upper problem, an upper quadrant problem. If it goes through the parietal lobe, specifically the dorsal optic radiation, it's going to cause a lower problem. Okay? And last, yeah.
Meyer's loop goes through the temporal.
Temporal. Because Meyer is a guy that you know from now on. Meyer's a guy that you know that has white hair on his temples. Okay?
With the optic tract injury,
yeah.
you lose basically the right side of both of your eyes is messed up, or the left side of both of your eyes.
Yes.
Okay. Yeah, that picture kind of sucks. Why is it one is on top and one is below?
What do you mean?
Optic tract and purple. Number 4.
Yeah, I'm sorry about that. I'll put a new picture before I send you guys the PowerPoint, and it'll be better. Okay?
What's wrong with
I want you to imagine that it's both these sides.
Okay.
There's a problem, okay? And which side will it be on? If you have a problem with the right optic tract, will you not be able to see, will you have right or left hemianopsia? Hemianopia. Left, exactly. Okay, and last is if you have it in the occipital lobe, the visual cortex, okay? If you have a, what kind of infarct, which artery? If you have a PCA infarct, you're going to have the same thing as which of these lesions?
4.
As the optic tract, I'm sorry it's bad, but you're going to have the same thing as the optic tract, except you're going to have what sparing? Where's the macula? The center of the eye. And last is, you guys know.
Wait, so isn't that the same as optic radiation?
What?
What you just said?
PCA is gonna cause lesions.
Yeah, the optic radiation. When they say optic, I'm going to find a better picture. When they say optic radiation here, they don't mean the dorsal optic radiation. They mean both the dorsal optic radiation and Mayer's loop. Okay? And that's why it would be the same thing as the occipital lobe, because those are the two things traveling to the occipital lobe.
Can you just explain Myers loop one more time?
Sure.
Just explain why is it that it's homonymous upper quadrant?
Sure. Okay. So Myers loop is in the temporal lobe. It goes through the temporal lobe, and then the dorsal optic radiation goes through the parietal lobe. Okay. The dorsal optic radiation gets lower. When the optic tract hits the lateral geniculate body, it splits into two. Okay. What goes upper and what goes lower. Okay.
This is after it hits the lateral geniculate.
Yeah. This is after it hits
so
the.
Whoever's in the Meyer is in charge of the upper.
Exactly, because the temporal lobe is lower than the parietal lobe. But since everything in the eye is reversed before it gets to the processing center, the visual processing center in your occipital lobe, things that were supposed to travel on the bottom will be things that are on the top. Things that you see on the top, your upper vision. Okay, so this projector for me and you would travel in the Myers loop, while the 4 would travel through the dorsal optic radiation. And I'll get a better picture. Do you guys get that? Okay.
Wait, we need to know the homonymous, what the fancy names?
Yeah, you should remember the fancy names. You don't need to know how to pronounce them. I still don't know how to pronounce them, but you should know. Well, you should there are only. Hemi means half. Okay. Anopia means can't see. Okay. Quadrant means 1/4. Okay. Anopia means can't see. So that's all you need to know. Okay. Homonymous means same side. Bitemporal is both temporal regions. You can't see. Okay. What do you guys think this is?
Horner syndrome.
Horner syndrome, okay? For Horner syndrome, you have ptosis, meiosis, and what's anhidrosis? Yeah, you'll never be told that the patient has anhidrosis because it's never, the patient is, not in real life, you'll never see a patient not sweating because the patient doesn't, you never put them in situations where they're going to sweat on one side of their face. But you do see the meiosis and the ptosis. So where does this come from? What is the problem here? Is it an SNS problem or a PSNS? A sympathetic or a parasympathetic problem?
Sympathetic.
This is a sympathetic problem. Do sympathetic problems come from the cranial nerves? No. Why is that?
They come from the sympathetic trunk.
Exactly. The cranial nerves only are sensory, motor, and parasympathetic. All sympathetics come from the sympathetic trunk. Okay? The sympathetic trunk is located where?
T1 to
T1 to L2.
Yeah, exactly. T1 to L2. Okay? And then it's going to expand. It's going to expand upwards and downwards from that level. So all sympathetics in the head, as roundabout as this is, come from your trunk and then move up the internal carotid, up the neck, and then go here. Okay? So that's why sympathetics such as meiosis, the big one being mydriasis. So since you can't have mydriasis, since you can't expand your eye, because expanding your eye is what? It's sympathetic. To expand your eye is sympathetic. Okay? Because when you're being chased by a bear or something, you want to see everything. So your pupils dilate. You lost that. Okay? If you have a problem, such as a lung tumor, that or someone hits your internal carotid and slashes it with a knife, but misses your actual internal carotid, but hits your sympathetic tract that travels up it, you're going to not be able to expand your eye anymore when it's, for instance, dark or when you're being chased by a bear. Okay, therefore you're going to have permanent meiosis. Okay. So this is a problem with mydriasis, which is why you present with meiosis. Okay? Yeah?
Is there any issue as far as accommodation of the lens?
The what?
Accommodation of the lens?
I don't know. Do you know accommodation?
Accommodation?
Yeah, will you have a problem with accommodation?
It's a ciliary muscle.
Wait, Henry, what was your question? One more time?
Is accommodation altered in this case?
I think it would be altered if you lesion the cranial member with
The ciliary.
because that way the parasympathetic would be cut off, and you have the opposite of these symptoms.
Yeah. You don't have exactly the opposite.
Except anhydrous. I think you have
And ptosis. You'll still have ptosis with parasympathetic lesion.
Accommodation
With the lesion and yeah, it's don't you guys. I've seen a few questions where it shows ptosis and mydriasis. Don't confuse it with Horner syndrome. That's a cranial nerve 3 lesion. Okay, don't confuse the two. I know since it's sympathetic and parasympathetic and you're turning one off, it gets a little confusing. If you see mydriasis and ptosis, okay, mydriasis, if you see it, that means you have a problem with parasympathetics, and therefore it's a problem with which nerve? The third cranial nerve. Okay? You'll still have ptosis for whatever reason. Okay? The thing that distinguishes the two is the eye big or small? Is the pupil big or small? That's how you're going to really distinguish between the two. Okay? All right. Any more questions on the? Did I answer your question? Did I answer?
Yes.
All right. Know the brainstem. I can't tell. On our NBME last year, we had like 10 questions on the brainstem, like where they just showed a picture of the brainstem, and they told you a very simple. It's the facial nerve, but then you had to know, like, which of these nerves is the facial nerve. One. So really know this. Know which area it comes out of. You guys know where all the nerves come out of, which side, which specifically midbrain, pons, medulla. There's a great page on first aid on it. Just, do you guys have any questions on it? Okay. Where does cranial nerve 7 come out of? Okay. Where does cranial nerve 3 come out of?
Between the superior cerebellar artery and posterior cerebellar.
Pay attention left and right. They'll show both nerves, so make sure you guys remember if it's a left lead or right.
When you have a pinealoma, which is a tumor of your pineal gland, which nerve do you damage? Why is that? Yeah, it's in the back and it loops around.
But does it go as
Yeah.
Could it go outwards and also press on the nerves or no?
You'll only see it within my experience. I've seen like one question on it, and it was optic nerve number 4 question. All right. The facial nerve. Do you guys understand facial nerve lesions? No. All right. So the facial nerve consists of what? Do you guys need to know the facial?
Yeah.
Okay, the facial nerve consists of, do you guys want me to do this next week?
No.
Okay, it consists of sensory, motor, and parasympathetics, right? I'm not wrong? Perfect. At this point, I don't ever know anymore. When they're talking about upper motor neuron lesions and lower motor neuron lesions, just like the corticospinal tract, there's an upper motor neuron and a lower motor neuron, and both lesions will present differently. But rather than up and down fasciculations, reflexes, stuff like that, they're going to test you on, okay, which side of the face does it affect, and does it affect the forehead or not? Okay? Now, the upper motor neuron will come from the contralateral side, and for just the forehead, it's also going to come from the ipsilateral side. So your forehead has an upper motor neuron from both sides, and the nucleus for the facial nerve motor part of below your forehead, below your eyes, this region, is only going to have innervation from an upper motor neuron from the contralateral side. Okay? Yeah. Sure. Okay. Yeah. So just like what's the motor tract of the body? Just like the corticospinal tract, you have an upper motor neuron and a lower motor neuron. And the way they're going to try to distinguish between the two is not by fasciculations and reflexes. They're going to try to do it through what side of the face is being affected. Is it the left or the right? And is the forehead included or not? Okay? So the upper motor neuron comes from the cerebral cortex, the motor cortex of the head, which is before the central sulcus or after, the pre or post? Pre-central gyrus. It's going to send motor signals to the nucleus, to the facial nucleus, which is located in which level of the brainstem? Pons, exactly. Okay, and the facial motor part, the motor part of the facial nerve has two nuclei. Okay, a forehead part and everything lower than the eyes part. Okay, the forehead part gets innervation from both the contralateral side and the ipsilateral side. The motor cortex from both sides, ipsilateral and contralateral, affects the forehead nucleus. Okay? Movement of my forehead is controlled by both sides of my brain. But movement of the below my eyes is only controlled by the other side of my brain. So if I want to move this part of my face, it's controlled by this brain. But if I want to control this part of my face, it's controlled by both sides of my brain.
Isn't that sensory though?
What?
Right?
What? No, this is motor. Facial, we're talking about facial palsies, facial nerve palsies. And it's the facial nerve is mainly a motor nerve. It has sensory parts, but when they test you on facial nerve palsies, it's motor. Okay.
So that's not the placental gyrus?
I don't know. Don't concentrate on that though. Because your brain is being sliced this way, if you moved backwards, then it would be your sensory drive. It could be, yeah.
for the facial nerve, does the upper part of the facial, do they both decussate? Like the facial nerve decussates as it comes across, right?
Okay, so the decussation occurs at the upper motor neuron. Okay? Just like for your corticospinal tract, which part of the corticospinal tract decussates? Upper or lower? Upper. Similarly, the upper motor neuron here decussates. Okay? Just it decussates before the level of the pons.
So he just said in class that the facial nerve, the upper part doesn't decussate, but the lower part does decussate.
Yes. So he's not talking about upper motor neuron and lower motor neuron. The upper motor neuron consists of two parts. A forehead part, aka the upper part, and the below the eyes part, the main part of your face part, aka the lower part. Okay? Upper part and lower part. Completely different from upper motor neuron and lower motor neuron. Is this what I see confusion on your eyes? Does that make it in any way better? Okay? Do you guys want me to repeat it one more time?
Yeah, can you repeat it?
Okay. Okay. So you have an upper motor neuron. Thanks. This is beautiful, so I'm not going to erase that. Okay. You have an upper. Okay, so from your cerebral cortex on both sides. Okay. I want you guys to imagine this is your cerebral cortex. Okay. It says, hey, I want you to move your face this way. I want you to smile. Okay? Here are your pons. Here are your nuclei. Right? Your upper motor neuron consists of two parts. Okay? A part that controls the superior part of your face, aka the upper part as your teacher was talking about in class, and the part that supplies the inferior part of the face, tells the inferior part of your face to move. That's called the lower part, as your teacher says. Okay? Okay? So your forehead muscles are get innervation, they're told to move from both sides of your head. Okay? From both cortexes. Okay? So over here, it's being, imagine this is the forehead nucleus, and this is your, let's say, mouth nucleus. Okay? Your forehead nucleus gets innervation from both sides of the head. Okay? Contralateral and ipsilateral. Okay? Your mouth region only gets innervation from the contralateral side of the head. Okay? In other words, your mouth is normal, just like the rest of your body. Your mouth is innervated by the contralateral side of the head, the contralateral side of the brain, while your forehead is abnormal. It's innervated by both sides. Okay? That's your upper motor neuron. Then you have a lower motor neuron. Okay? The lower motor neuron comes from, that's the facial nerve that you see coming out of the brainstem, coming out of the pons. Okay? That's your lower motor neuron of the motor part of the facial nerve. Okay? There, it goes to the same side of the face that it comes out of. Okay, so if it comes out of the left side of the pons, sure, it originated from the contralateral side, and for the forehead, both sides. But it comes out, so if it comes out of the left side of the pons, it will innervate the left side of the face and tell the left side of the face to move. Okay? And it's very simple. Can I get the, yeah. It's very simple. In blue is your upper motor neurons. In red is your lower motor neurons. Here's your face. Okay?
So it's kind of hard to see the podium.
Oh, yeah, sure. Sorry about that. Okay. Sorry, David. Okay. You guys, what am I drawing over here? These are your pons, okay? Here's your face. Your lower motor neuron is going to come out of the pons. This is your facial nerve that you always see in the coming out of the brainstem that I just showed you. Okay? Over here, the forehead part. Okay, let's pretend that it's made of the lower motor neuron is made of both red and green. Okay? The mouth part is going to go innervate the mouth on the same side. So assuming this is the left side, since we're doctors, assuming this is the left side, it will go innervate the left side, while the lower motor neuron from the forehead is going to go innervate this region. Okay, the forehead region. Would you guys like me to redraw the upper motor neuron again?
So I'm just
I'm just confused. We just said the lower part does deficit, so where does it
No, the upper motor neuron decussates. It's always the upper motor neuron.
there seems to be two things, contralateral, and then there's decussation.
Yeah.
So there's a contralateral component on each part of the face, but there seems to be this lateral addition of the forehead as well. Now, the issue is, where is this decussation occurring? That's the question.
The decussation occurs in the upper motor neuron.
Ipsilateral.
Yeah.
The question is where is the decussation occurring? Because with the upper and the lower, it has nothing to do with the upper motor neuron and the lower motor neuron, but like the upper part and the lower part. So there's decussation on the upper part where it's just the forehead.
Yeah.
There's decussation at both. So you're talking about the so we have the upper nucleus and the lower nucleus.
Right.
The only decussation that happens above this. So only the upper motor neurons will decussate, regardless of if it's going to the upper nucleus or the lower nucleus. They both decussate. What he's just saying is that only for the forehead, you get decussation and innervation from both sides of the cortex. So that's the only
decussation occurs for both.
For both, okay?
For both, yeah.
And only decussation occurs for upper motor. Whenever you think of a lower motor neuron lesion, the lesion is the same size as what you're going to see, okay? So if you see a left facial droop, then it's going to be the lower motor neuron is on the same side. The upper motor neuron, depending on if it's forehead or lower part of the face, they'll tell you which side it is, because you know that the forehead is from both sides. Does that make sense?
Yeah, so if there's, let's say, a lesion on
So you give me an example. Go.
There seems to be, like, let's say there's a lesion on one side of upper motor neuron for the forehead, you could still have partial paralysis with two types of innervations.
Yeah, so let's say there's a upper...
Contralateral, let's say.
Let's say
Start with the lower motor neuron.
Okay, so if you had a lower motor neuron lesion, you're going to get paralysis of the entire... So let's say this is me, okay? My nucleus right here, these are where the lower motor neurons originate. These are all lower motor neuron. These are ipsilateral, right? Same side of the face. So a lesion here is going to give me a facial droop of my entire left side, forehead and lower face, okay? Now, let's say the lesion is not the lower motor neurons. Let's say it's the upper motor neurons, right? He's saying that if the lesion is an upper motor neuron lesion, so let's say, remember you have, so let's say here's your...
Let's say it's a stroke.
Here's one side of your brain, here's another side of your brain. What he's saying is that for this upper nucleus, you're going to get both innervation from the left side of the brain, as well as an ipsilateral innervation to the brain. So even if you have a lesion of an upper motor neuron, the other side is still going to innervate the forehead area, so this part is going to be preserved. That's what he's saying.
So partial paralysis.
Partial paralysis, if it's an upper motor neuron lesion. If it's lower motor neuron, complete paralysis.
But upper motor neuron for the lower part of the face will still be full paralysis.
Full paralysis, because it's only one. So let's say if I have the lesion on this side, you're going to get an contralateral, complete paralysis of the right lower face.
But you're still going to have innervation from the ipsilateral brain
For upper part.
for the upper part.
Yeah. Yeah.
For the forehead.
For the forehead. Why?
Yeah.
If we're talking about an upper motor lesion for the
Yeah.
forehead, it's still partial paralysis.
Yeah, if you have an upper motor neuron lesion for the forehead, if you have an upper motor neuron lesion of the facial nerve, it's going to be, you're just going to have drooping of the lower part of the face. And the reason for that is because you still have ipsilateral innervation from the brain for just the forehead.
There are multiple upper motor neurons, though, and it's not just one upper motor neuron.
What do you mean?
I'm saying if there's a lesion for an upper motor neuron, you'll have a lower paralysis, you'll have preservation of the forehead since it's lateral, but who cares? There's multiple upper motor neurons for different parts of the
Just think of it as one thing. Think of the forehead all as one, like
one upper motor neuron.
Just think of one upper motor neuron that's innervated. I think, okay, so just think of one. I know you can think of like different parts of the forehead. Just think of it all as one muscle being innervated by one nerve.
So everything's just coalescing into one upper motor neuron.
Think of it like that.
And so if you cut the upper motor neuron, there will be full lower facial paralysis due to the fact that it's only contralateral. However, the forehead will have partial paralysis because it's lateral innervation.
Forehead is preserved. Right.
All right, guys. So just if you guys had it on the last test, it's not going to be on this test. I will find a better way of explaining it for the NBME, and yeah, okay. This is just the summary of what we've been talking about for the past 50 minutes. The lower motor neuron lesion. You guys did it. Yeah, we did it. All right. Here are your questions. All right. Who wants to read?
60-year-old man presents CDR after losing consciousness, and CT angiogram shows occlusion of the left anterior cerebral artery. Which of the following symptoms would you expect on awakening?
Okay. The left ACA supplies which part of the brain? The ACA supplies which part of the brain? The medial aspect. And what's on the medial aspect? The lower limbs. So this is going to be a lower limb answer. Is it sensation or motor? Both. Perfect. And will it be on the left or the right side? Why is that? Because, yeah, it crosses over. It decussates. Okay? So what do you guys think the answer is? Which one? D. D. All right. A 6-month-old child is diagnosed with? Okay. This is basically polio. Okay? It's genetic polio. And what did I say genetic polio is? Lower. It's a lower motor neuron lesion. Okay, so which of these things do you see with lower motor neuron lesions? Fasciculations. What else would you see? Yeah, decrease everything else. Babinski sign, you're going to see that in? What? Normal in babies, but you're going to see it in? Upper motor neuron lesions. Can anyone show me? Everyone stick up your foot. Show me what Babinski is. Perfect. Okay. Spastic paralysis is going to be seen in? Upper motor neuron. Increased tone? Increased reflexes? What if you had a patient presenting with all 5 of these? What would you think? Perfect. A 45-year-old man comes into your office with chronic cough. On examination, you notice that his left pupil is constricted. Is that meiosis or mydriasis? Meiosis. Good. Based on this alone, where is the lesion most likely? What? So, sympathetic trunk. Which one? Left. Why is that? Is this an SNS or a PSNS lesion? SNS. If it was PSNS, which would it be? Yeah, no, it wouldn't be opposite, but it would be. Do you mean that it would be? You'd have big eyes. You'd have. Okay, so what is this called? Horner syndrome. What do you guys think he has?
Carcinoma of the apex of the lung.
What? Yes. He has some sort of lung cancer. For what? It's less because there is no section. Yeah, just go straight up. And what does it travel up on? The internal front. Why is it not D? The right oculomotor. C. Left oculomotor nerve. Okay. The reason is because you see a constricted pupil. Okay. That means what's not working? Sympathetics. You're not able to dilate your pupil. Okay. Since you're unable to dilate your pupil, it stays constricted. You're going to have a patient who's sitting down in a dark room, and he still has one constricted pupil, the other one is normal and dilated. But this one's constricted because the sympathetics aren't working. Okay? So because the sympathetics aren't working, it's a constricted pupil, and therefore, can't see. If it was a dilated pupil, you'd suspect a... Yeah. Then you'd suspect oculomotor.
And would it be on the opposite side?
What?
Oculomotor opposite
I'm pretty sure it's on the same side, but I'm not positive. Okay.
Let's go to the next question.
All right, Div.
Okay, pain and temperature. Which tract?
Spinal cord. Spinal cord. Where do all the others decussate? Good.
Patient presents with inability to comprehend when spoken to, inability to write, no issue speaking, speech is incoherent, and patient does not seem distressed. Which of the following lesions?
He has no issue speaking.
What do you guys think this guy has? Wernicke's.
Wernicke's or Broca's? Which one? So remember, he can still speak, okay? He can still speak. Although it's not coherent, he can still speak. His biggest thing is he can't comprehend, okay? So this is a Wernicke's. And which side of the brain do you see Broca's and Wernicke's? So it's
honestly, I don't know. It shouldn't say inability to write, so I apologize. He will be.
Broca's and Wernicke's are all the way.
Sorry, he shouldn't be. Guys, the answer will, no matter what, here be left MCA. You're right. He should be able to write, and that's a problem with the question. I apologize.
So totally happy with the answer, but if he has the inability to write, is that not the arcuate lesion?
No, arcuate. It would be. Tell me to repeat something.
But I thought it was like, then you also put, okay, never mind.
A problem with the arcuate fasciculus is, say, sheep's like cheese. 99.
You don't understand it and you can't produce it.
What?
Okay.
You can understand, you can produce, you can't repeat. That's the problem. If your Broca's area and your Wernicke's are intact, and the only problem is that the connection between the two is severed, then it's going to be you can't repeat the person. That's the only problem.
Is Broca's and Wernicke's on the left always?
Broca's and Wernicke's is on the left in 99% of patients.
So there's nothing on the right?
On the right, we'll learn that next year, but for your purposes, there's nothing that you need to know on the right.
Michael?
Yeah.
Either now or after, can you go back to like question 2? Can you do it? Alright, fine. Can you do it?
Okay. Just remind me, okay? Jeremy.
Patient is diagnosed with syringomyelia. What was the first symptom experienced?
So, syringomyelia, what does it,
Anterior commissure.
it affects the anterior commissure. What is the anterior commissure for? Pain. Pain and?
Temperature.
Temperature. Which tract is that? Okay, so which of these answers was the E? There you go. Loss of fine touch. That would be a problem with? Dorsal. Loss of motor abilities would be a problem with corticospinal. And where does the corticospinal decussate? Medulla, good. Loss of ability to speak?
MCA.
Left MCA. Hemiparesis? What? Hemiparesis is paralysis on one side. So that could be either, that could be that could be so many different things. But so syringomyelia is going to start out as loss of pain and temperature at that point, and then it's going to expand and affect everything. But first thing, loss of pain and temperature. Hemiparesis is loss of movement on one side of the body.
What would that be caused by MCA?
What? Yeah, that would be an MCA or an ACA infarct. It could also be a spinal cord lesion of the motor tract. Okay. There are like 3 more. Someone, anyone.
65-year-old woman is brought to the ER complaining of the worst headache of my life.
What is it?
Subarachnoid hemorrhage.
Perfect.
Want me to read that?
What? No. Yeah, finish.
Formal lumbar puncture at levels of 3 to 4. What is the final limit that you will go through to receive this?
Where are you getting CSF from? The subarachnoid space. Subarachnoid. Under the arachnoid. Okay?
If you go a little further, you're going to hit the PF, and then you go to.
And then you go to where? To the spinal cord, and that's not good. That's why you do it at which levels?
After L3.
Yeah, because the spinal cord ends there. Okay? So when would you do a lumbar puncture, guys?
Meningitis.
This and meningitis, right. Which of the...
7.
Yeah. Okay, and you guys should be able to look at the brainstem and identify.
Where does it go through? Granular 7.
Internal alternative.
And what else goes through the internal auditory meatus? All right, guys. We have a few more, and then you guys can go and enjoy life. Sorry. A 96-year-old man has a stroke of his left PCA. Which of the following problems is he most likely to have upon examination? Okay, you guys, the PCA, what is it going to affect? The occipital lobe, okay? When it's an occipital lobe lesion, what are you going to have? What? Yeah, you're going to have a problem with the opposite side, but except for one part. What's that part?
Macula.
Macula. If it was full right hemianopsia, what would it be? Where would you see the nerve? What? Optic tract. No, I'm sorry. It should say hominopius hemianopia. Sorry, but if it's just your eye, if it's just one eye, then it's going to be the optic nerve. If it's hominopinous hemianopia, which is where you see it for just one side, like your left side for both eyes, then it's your optic tract.
So what does hemianopsia mean?
Hemianopsia means not being able to see on half of your vision. You'll see, I don't think it's called hemianopsia for just the optic nerve. I think they just say your eye can't see.
For the optic nerve, they just basically say blindness in one eye or something like that.
Yeah.
Why isn't it left hemianopia with macular sparing? Because if your
It
left
is.
PCA,
Oh.
if your left PCA is occluded, then and you're saying that you have partial sparing of the right side.
Michael didn't raise my picture. I wish
Because it goes to the opposite side.
Okay.
Once it decussates at the optic chiasm, it goes to the opposite
The
side.
PCA?
No, it's a
Oh,
PCA.
you're, no, it goes, no, it goes to the, it's because the stuff on your right side goes to your left occipital lobe, while the stuff on your left side goes to the right occipital lobe. Okay? I should have written right heminopius, hemianopsia.
Last one.
And last question. A 23-year-old man cannot see with his right eye. Where is the lesion most likely? Right optic nerve. Okay, one more, guys. This is the last one, I promise. A 23-year-old man with a lower motor neuron lesion of the facial nerve will present with...
If you get this right, you can go.
No, everything.
E. Ipsilateral paralysis of both the forehead and the lower face. Okay? These are good resources, and don't really explain it to each other. It makes things a lot clearer. Okay?
Wait, this is from like the beginning.
Thank you, it was very good.